Moving on, our next presentation is by Dr. Raju R Nair, Director and Head of the Department of Reproductive Medicine at Mithera Hospital, Kottayam, on the topic Follicular Synchrony in IVF. Let us welcome Dr. Raju R Nair to the stage. Over to you, Doctor.
Good afternoon, everyone. First of all, I thank Jayesh sir for the invite and respected senior faculties and dear colleagues and dear chairperson. The topic today is a very interesting thing. There is a harmony in synchrony because nowadays we do see a lot of IVF being done and ending in a difficult scenario of asynchronous follicular development. So the crux of an ovulation induction, or basically the objective of an ovulation induction, is induce multiple follicular development. Because nowadays we think that getting one oocyte or two oocyte is not the aim. Getting a cohort of oocyte or mature oocyte or a cohort of embryos should be your aim in manipulating the follicular genesis. So we have a normal responder, we have a hyper responder, and we have a poor responder. Unfortunately, now we do have a proper definition for all these things. But nowadays we come up with a more difficult scenario is called hyporesponder. So what is an hyporesponder is still a big enigmatic thing because it's an unexpected ovarian resistance to ovulation induction with standard dosage as per the age, BMI and the biomarkers, but patient responding in a better way. This is called hyporesponder. So for a normal responder and hyporesponder patient, getting a very minuscule of follicles recruited or minuscule of follicle aspirated, we call it this condition. I'll take your attention to two terminologies. One is asynchrony and one is suboptimal response. The meaning of asynchrony is that when 50% of the stimulated follicle reach the mean diameter of around 14 millimeter at the time of cancellation, that means the follicle has grown. It's not that it's stagnant, but unfortunately it's maybe 15 follicles were at the beginning, and at the time of pickup or at the time of HCG trigger, we are seeing 50% still at the stagnant phase of around 12 or 13. So this is called asynchrony. Suboptimal response is actually a retrospective diagnosis that either the development of less than 5 follicles of more than 12 millimeter in a patient who is supposed to have a good AFC or aspirating less than 4 mature oocyte. So we can say that all asynchronous response are suboptimal, but all suboptimal responses are not asynchronous. So that is the crux of my topic. So how we identify this? We know that we have something called biomarkers. Biomarkers are AMH, AFC, serum FSH, all sort of thing. But these biomarkers represent a static snapshot of the individual ovarian response and do not properly reflect the dynamic nature of the follicular growth response to exogenous gonadotropins. So we need to have an idea what is actually happening when the follicular stimulating hormone is pumped into the body and how the follicle is start to evolve. So we have some dynamic indices into play. One is follicle output rate, follicle to oocyte index, OPF, and ovarian sensitivity index. But the first two is gaining a lot of momentum, and especially the second thing. The first one is the number of pre-ovulatory follicles. Suppose we have, say, 7 AFC number of 10. Antral follicle count on day 2 was 10. And on the day of trigger, suppose we are getting 9 dominant follicle. That is called follicle output rate. In follicle to oocyte index or FOI, we are taking one step further. That means number of oocyte retrieved per antral follicle count. Suppose we have 10 AFC, how many oocytes we are actually retrieved? If you are reaching up to 10, we are getting a good response. If you are not retrieving 10, obviously we are having a abnormal response to the follicle, maybe because of asynchronicity. So 40 is simple. If suppose we have many follicles, majority of the follicles ending up to hyposensitivity, obviously just on 30%, but majority 80% will have an adequate response. This is a very important criteria of FOI. Look at the FOI more than 50 and less than 50. The more than 50 cases, suppose a PCO patient, when stimulated at the end, will get more number of oocyte, and a normal responder will get a normal response. But if the FOA is less than 50, a hyper-responder patient supposed to be ending up in a very poor response, and a poor responder patient ending up in an extremely poor responder. So why this happens? So I'll take you to one of the important pathogenic mechanism of why this hyperrespondence is happening. That is called asynchronous follicle development. And why this happens, how it happens, how we can improve it. So overview of my presentation is to take you to the biological basis of follicular development, techniques of follicular synchronization, challenges and consideration, and obviously what are the future directions to be. So why this follicular synchronization is very important? Because if you are getting good quality oocyte, it obviously end up in good quality embryo and a take-home baby. So improved response to ovarian stimulation is the base of any IVF cycle. So if your response is inadequate due to some mechanism, some fault, you will be ending up in lesser number of oocyte. So oocyte yield will be less. And if you are getting up a lesser oocyte yield, the hormonal milieu, maybe the endometrial priming, all sort of thing can also be affected. So you may have a decrease in implantation. And the more importantly, if suppose you are going ahead with a donor stimulation or a cancer patient with oncofreezing or something, your predictability of cycle outcome can be wrong, and improving the fertilization rate in some odd patients and enhancing the embryo development. So in all aspect of IVF, this follicular recruitment and the follicular synchronization is very important. So the clinical implication is not only for a poor responder, it is important for a poor responder, for a PCO or a hyper responder to prevent the follicular dominance, and in normal responder to have a more cohort of follicles growing in the right direction. So before venturing in little bit deeper, I will take you little bit on the physiological aspect of follicular development. We know that when the normal follicular genesis, we have the previous cohort or the random stimulation, all sort of things gone, and now we know the wave theory of follicular genesis. So in this wave theory, majority of the individuals have at least two waves. That means from one menstruation to another menstruation, usually after the phase of an ovulation, there will be another surge of follicular wave happen. And why that wave happens, you can see there is a rise in the FSH level at that point. So when there is an FSH elevation, obviously the follicular recruitment happens. So in 30 to 40% of the patients, there have more than two. That means one at the time of early follicular phase, second at the time of ovulation, and third just before the luteal transition. So if you manipulate these areas, or rather with this physiological mechanism, if why this FSH signaling happens and how we can modify this FSH signaling to our merit, we can have an insight on the follicular synchronization methodology. So what is the mechanism which happens in the intercycle, or maybe from one menstrual cycle end to another menstrual cycle start, or why that follicle is going to start to grow into an adult follicle, is basically a concept called FSH signal. The FSH signal is on an average 2.5 million of ml of amplitude of FSH is actually required to produce this transition. And in our humans, this is destined to become only one oocyte to grow. And what is the major determinant of this FSH to maintain or suppress or halt is actually your estrogen levels in your body. So during the intercycle interval, there are two hormone signals drop in the luteal phase. What are they? One is estrogen will come down and the progesterone will come down. So these two hormones will have two diverse functions. The decrease in the progesterone will ending up in next menstruation because the endometrium will start shedding. But the declining in E2 is actually the mechanism of the next wave of follicular recruitment. This is an interesting slide. So you can see that the yellow line is E2. So when there is a decline in the E2, you can see the pink line, the FSH start rising. So usually in a normal patient, in a control cycle, once the E2 comes down at the time of menstruation, within day 3, you can see the peak in FSH and the follicle recruitment happens. But if suppose we are giving estrogen simultaneously along the luteal transition phase, you can see the FSH is not getting elevated. So FSH is getting stagnated there, and the moment estrogen declines, you can see the FSH start rising. This is a basic funda of how an estrogen prime stimulation works, because we are halting the FSH stimulation to grow by virtue of the adding estrogen in your body. So why this heterogeneity of the follicular growth happens altogether? It may be because of two reasons. One, FSH rise in the late luteal phase and may cause a premature dominant follicle selection. Because if suppose a normal mechanism is not happening, different follicles has got different FSH receptor levels. So if the FSH receptors are odd, then a dominant selection happens before the cohort is getting selected. So one odd follicles may get selected and continue to grow. So this why the heterogeneity of the follicle growth happens. Then how we can improve this follicle synchronization? This is broadly divided into three types. One is pre-treatment approaches, cycle initiation changes, and the stimulation phase adjustment. We'll go one by one. First is pre-treatment approach. This is the gold standard of giving OC pills. So we all give OC pills for batch IVF, for synchronization, or maybe to get all the patients in a time. So what actually happens is that we give estrogen and progesterone in the luteal phase, maybe 12 days or 16 days or 21 days, whatever be the time, so that the E2 level will be maintained and the patient will get a proper withdrawal bleeding and the follicles start. So basically we are getting a synchronized follicle growth. This is a very time tested thing, but it has got some side effect, and there are, especially in antagonist cycle, there is a lot of papers has come up that if you use OC pills as a pre-treatment, it decreases the chance of pregnancy or the live birth rate. And another problem with OC pills is that if you use prolonged, say more than 15 or 16 days more, it will give you a suppression. So you may require more of gonadotropins. It may create something called dual suppression effect. So more of gonadotropins may be required. And there is a concept about pill-free interval. So there is a study by Grisinger et al., a meta-analysis in Cochrane. So this is a study proved that the live birth rate, especially in an antagonist cycle, if you give a pre-treatment, the live birth rate is low. But that study is actually skewed by the two papers, or the maximum number of individuals in these two papers, where the pill-free interval was less than 2 days. So the estrogen hasn't washed out. So if you stick to this 5-day pill-free interval or 5-day time interval between the stop of OC pills and the start of stimulation, obviously the E2 comes down, the follicle synchronization happens, and the follicle yield will be better. So if you are using OCP as a treatment, always keep in mind that we have to always use this minimum of 5 days of gap before the start of stimulation. Then coming to interesting concept of estrogen priming. I already explained why this estrogen priming, or rather how this estrogen priming is useful, because estrogen will decrease the FSH threshold or FSH amplitude, so that the FSH will be in a standstill mode. So the moment estrogen comes down, the FSH starts reducing and the follicle recruitment happens in a simultaneous way. And estrogen priming can happen either at the luteal phase or at the follicular phase. So what is a luteal estrogen protocol? In luteal estrogen protocol, from day 20 onwards, we give 4 milligram of estradiol valrate till day 2. So what is the problem? We are giving E2 at a consistent level throughout the late luteal to the early follicular phase. So in those time, the FSH signal is actually getting arrested. The follicle recruitment will not happen. So the time we get the period, we decreases E2, gonadotropins will be added, the follicle selection happens, and the response will happen. Another interesting paper by Manish Banger is based on the use of estrogen in follicular phase cycle programming. What he did is mainly for the donor patients. What he did was, donors received 8 milligram of estradiol hemihydrate from day 2 till day 1 of before stimulation. That means if the patient had a menstruation, we can just prolong the stimulation by just giving 8 milligram of estradiol hemihydrate for the subsequent days till the time you want. So as long as you give estrogen, there won't be any recruitment. So we can continue according to our timing. Suppose the recipient is ready, or suppose we have a conference on Sunday, all sort of things can be manipulated by this follicular phase estrogen support. Then coming to GnRH antagonist priming. GnRH antagonist is a fantastic tool in priming because it dramatically decreases FSH and LH. So we can have a suppressive effect on the FSH so that the stimulation can be delayed. And this antagonist priming can also happen either in the luteal phase as well as in the follicular phase. The follicular phase antagonist protocol, suppose the patient had a period, and while we do scan, we see that there are few follicles are there, but one follicle is some odd, maybe around 10 millimeter, 12 millimeter one follicle, and some other follicles are not very coherent. In those scenarios, we are more or less certain that if you stimulate blindly, that dominant follicle become an asynchronous follicular development. In those subset of patients, if you give GnRH antagonist 0.25 milligram for say 2 to 3 days, we actually reduces this surge and there will be a synchronization and the follicle yield will be better. And this can be clubbed along with estrogen also. So usually in the pre-treatment arm, GnRH antagonist will be given from second to maybe 2 to 3 days, and normal stimulation happens. An advantage of this is that the number of cumulus oocyte complexes received is actually much more. But the pregnancy rate is not that improved, even though the number of oocytes are improved. So this is a mechanism. Suppose those labs where embryology is not in place, we want to say push stimulation for 2-3 days more. This is an approach. But by doing this, we are indirectly improving the follicular synchronization also. And we can have antagonists plus E2. What do we do? Estrogen priming in the late luteal phase to the early follicular phase, and then GnRH antagonist in the early follicular phase. So these two will combine the effect of suppressing the E2 level, and we can program the cycle at a better phase. So these are the different antagonist protocols. Then the luteal phase suppression is a gold standard. That's a previous all long protocol that we on day 21 we give GnRH agonist, either a continuous or a depot, so that entire receptor get internalized. So we'll get a cohort of follicles to recruit and a uniform stimulation will happen. But the problem is, especially with PCO and all, we have no control and ultimately land up in ovarian hyperstimulation, and nowadays it's an off-flavor thing. Then coming to cycle initiation strategies. This is actually not into the preview of follicular synchronization, but it can be considered because these are the scenarios that we have to stimulate in a short period. That means at very odd phases, something called random start stimulation or in dual stimulation, especially for a oncofertility or other difficult scenarios which come into play. So mainly poor prognosis patient with severe risk of iatrogenic infertility, oncofertility, and egg donation program. So I'll sum up in lack of time. There are mainly 3 things. The conventional start, because bleeding to bleeding, the mid-cycle is ovulation. So conventional start is the usual follicular start, and the follicular start can be early follicular start as well as the late follicular start, and there can be something called luteal start, and there can be something called luteal hold protocol. That means we hold the luteal phase progesterone by giving some medication and then start the stimulation, and last the dual stimulation. So there are different methods we can do this cycle programming to get a cohort of follicles recruited in a similar fashion, especially in this subset of patients. Okay. So then the stimulation phase adjustments. So basically step down and stepped up protocols. So suppose we are, especially in a patient with PCO, if you are seeing that the follicle recruitment is started very fast. If you do a step down regime, what will happen? Usually we feel that the follicle cohort may get a stagnation. But if you have crossed that FSS threshold and is maintained, obviously the recruitment starts in a big way. And similarly, if you are seeing that the follicles are not responding the way needed, is getting stagnated, adding LS may be a tool to it. So manipulating with hormonal and ultrasound and step down and step up regimes, you can actually play around if there is no inherent pathophysiological mechanism already prevailing. So to sum up my slides, I just put a SWOT analysis on this follicular synchronization ART cycles. So what are the strengths? Is improve the ovarian response and oocyte yield, definitely is beyond doubt. Reduces the follicular asynchrony, leading to better embryo quality. Enhances the cycle predictability and reduces the cancellation rate, and suitable for wide range of ART patients, including poor responders and fertility preservation. The weakness is additional pretreatment may extend the treatment duration majority of times. hormonal manipulation have some side effects like mood swings and all, and some protocol requires strict patient compliance and monitoring because we cannot have the freedom. The opportunities, it creates a lot of avenues for us to explore and manipulate the oocyte. And the threat, obviously ethical concerns as very much, and the variability in patient response can affect the outcome. And we do need much more larger data on live birth on this follicular synchronization and the output. So to conclude, follicular synchronization is very crucial in ART to maximize the mature oocyte and improve the embryo quality and improve the pregnancy rate. And we have to judiciously use this depending on the patient characteristic, ovarian reserve, previous cycle response. Thank you.
Thank you so much, doctor, for that excellent session.